Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Welcome to IMR-SEAMEO webinar series 2021. And this time around, we present to you a special edition of the series of webinar. This time around, we collaborate with College of Public Health Malaysia and alumni of Epidemic Intelligence Program of Malaysia, or EIPMas. I'm Dr. Anita Sulaiman. I'm going to be your moderator for today's webinars, and today's topic is combating COVID-19 the unusual way. Thank you to those who are able to join our webinar today. A little bit on the rule of a webinar today. There will be no verbal question and answers. Question and answer sessions will be conducted after all speakers have presented their thoughts in this webinar series. Participant can ask question using the question submission link or in the chat box on your right. And there will be a link provided in the chat box as well. Only one or two questions from participants will be given to each speaker for question and answer session, and kindly state the panelists whom you would like to direct your question. Questions from participants not answered during live webinar will be answered by speakers through email. An attendance link at YouTube is provided for participants that would like to receive an e-certificate of attendance. The link is only valid during the live webinar. And don't forget to subscribe our YouTube channel. Let me introduce you. We have four panelists today from Selangor Health Department and Institute of Medical Research. They will share their experience on how they manage COVID-19 in Selangor at different levels of intervention. Our first panelist is Dr. Salina Taib. Dr. Salina is a public health medicine specialist from Medical Division, Ministry of Health Malaysia. She has 22 years of working experience in hospital and health clinic. She has vast experience in the field of public health, and during COVID-19 pandemic, Dr. Salina directly involved in case detection and contact tracing with a surveillance team at Petaling District Health Office. And we all know Petaling District is the district that is worst hit by this pandemic. Her topic is tracking COVID-19 pandemic threat through usual and unusual way. Over to you, Salina.
Right. Thank you, Madam Chair. Assalamualaikum and a very good morning to all. Thank you for giving me the opportunity to share the Petaling District experience in tracking COVID-19 to the unusual way. This is the content of my discussion. We all know that case investigation and contact tracing are the core of disease control measure. Tracking COVID-19 cases help to identify their sources of infection and their contact. We can inform the contact that they might be exposed, warn them for testing, and isolate if they are positive. This cascade will prevent further spread of COVID-19, thus breaking the chain of transmission. COVID-19 tracking can be done through manual, digital, or even hybrid methods. There are many advantages of using digital tracing method, especially when dealing with a larger size of epidemic. It's simpler to use, save healthcare workers' time, improve accuracy, and secure larger data set. However, it will incur higher initial cost and training, technical problems, and variability in internet access. In Malaysia, the Prevention and Control of Infectious Disease Act 1988 has warranted all COVID-19 cases to be notified to the JRS-THO in Section 10, contact tracing and its sequelae in Section 11, 14, and 15. Any person guilty of an offence under this Act shall be liable either for conviction or conduct. Let us talk about Petaling District. DHO Petaling covers an area of 400 kilometers square with an estimation population of about 2 million. We are the first district in Malaysia affected with COVID-19, and up till now, cases escalate daily to a cumulative number of about 194,000. Selangor is one of the states hit badly by COVID-19. 1/3 of Malaysia cases come from Selangor. It has an incidence rate of about 196 per 100,000 population. About 30% of Selangor cases come from District Petaling, with an incidence rate of about 113 per 100,000 population. All COVID cases will be investigated upon receiving notification. This will initiate a cascade of other case finding through contact tracing and screening. Positive cases will be sent for isolation, admission and treatment, and eventually curbing the disease transmission. DHO Petaling Outbreak Management Committee divided its human resources into essential teams, including case investigation and contact tracing. Each team consists a minimum of 10 to 20 personnel. Their working hours are from 8 a.m. to 5 p.m. and sometimes up till late night. Average daily cases ranging from 300 to 3,000 and contact numbers are ×5 of cases. This table shows an estimated capabilities of our case investigation and contact tracing team. About a year prior our innovation, our average daily COVID-19 cases are around 300 and we take a minimum number of 5 contact per case. About 1,500 people need to be manually investigated. Back then, our team only consists of 10 staff for case investigation and about 20 for handling all tasks related to contact tracing. Time spent to investigate each case or contact are about 20 minutes. We are able to investigate daily about 30 cases or contact per staff. Ultimately, only about 80% of cases and 40% contacts could be reached. This leads to continuum of disease transmission, increased healthcare resources needed, and burnout among healthcare workers. In January 2021, after a year being hit by pandemic, we developed an in-house web page especially for COVID-19 aimed mainly for self-reporting as well as providing information pertaining to COVID-19. All COVID-19 cases notified to us will be text through an IMR system. This message will consist of patients' COVID test results and a dedicated URL address that link to the website for them and their contact to fill up. We noticed that only 40% of cases self-reported through the website, thus manual investigation still needed. Okay. This is the website. The dashboard consists of 2 main parts, the self-reporting part and the information part pertaining to COVID-19. Let us peek through quickly to the website. Okay. If you are positive, you just self-report to COVID-19. Okay. Right. All questions are in Google form. It's user-friendly with 2 languages and easy to understand. Patients need to self-report their social demographic, risk factors, past medical history, and COVID-19 related information. They can also book their appointment for COVID assessment center. COVID-19 cases need to share the URL link with their contacts. Data entered are verified and cleaned up by the surveillance team before shared with other outbreak management teams for case investigation, admission, COVID assessment center planning, contact tracing, and investigation. These new innovations are lean by reducing the time consumed for the data gathering for both case and contact. This will eventually reduce the work burden and resources with better achievement. 8 months post-innovation, data showed that only about 14% cases use the website. Thus, manual investigation still needed. But the number of cases not reached are reduced even with a huge increase in COVID-19 cases notified daily. The outcome are almost equal in contact tracing, even though the percentage not reached still high. In conclusion, case investigation and contact tracing are the essence for COVID prevention and control. As outbreak grow, conventional way of prevention and control will drain the resources, thus ineffective in outbreak management. Despite many challenges, ICT usage helped to increase the capacity of COVID-19 tracking program. This is some of my reference. With that, I thank you.
Thank you very much, Dr. Salina. Indeed, digitalization has a positive impact in public health measures. So again, I would like to remind for those newcomers, if you have any questions and answers, please write in the chat box, or you can go use the question submission link either in the YouTube itself or send to your email. Okay, our second panelist is Tengku Rogayah, Tengku Abdul Rashid. Tengku Rogayah is a senior researcher with Virology Unit, Institute of Medical Research. She's the person behind the scenes. Apart from her research endeavor, Tengku Rogayah has important tasks in her hand, which is to ensure timely and accurate lab reporting of COVID-19 test results. And this is key to prompt public health action at ground level. So her topic today is COVID-19 lab role, keeping up with SARS-CoV-2. Over to you, Dr. Tengku Rogayah.
Thank you, Dr. Anita. Assalamualaikum and very good morning to all the panelists and all the audience out there. First of all, I would like to thank Dr. Fauzi and his team for giving me a chance to talk about the laboratory role during this pandemic. Sorry. Okay. Okay, in this short presentation, I will cover the timeline of the testing in our laboratory and also our functions as a diagnostic and also a research lab in this pandemic, and how we progress as a research lab and also what we can learn from this pandemic. Okay, even though when we communicating, we use term COVID-19 virus as what has been suggested by WHO to avoid unnecessary fear for some population, for the public, especially the Asian population who has experienced SARS outbreak 2003. But we cannot deny the fact that both of these viruses are closely related. SARS coronavirus 2 is genetically 80% similar with the SARS coronavirus in 2003. And SARS coronavirus is the RNA virus and is very prone to genetic evolution with the development of mutation over time. And most of the mutations have minimal or no impact on virus properties. However, some mutation may lead to substantial virus properties, spreading ability, disease severity, efficacy of vaccines or diagnostic tools, as what we have seen in recent Delta variants. And how contagious is the Delta variants? Based on the research finding, Delta variant, which predominating infections across the global recently has been proven to be more transmissible as compared to the original strains, which are Wuhan strains. So that made the intervention such as contact tracings, testing and isolating became very crucial to reduce the transmission. And as for every diagnostic laboratory, the main mission is timely and accurate result despite whatever tests we conduct. But this time around, the mission became very extra important due to the factors such as viral transmissible ability and also the impact of the pandemic to the country. And for the laboratory to achieve the mission is through 4 key elements. This is main key element. The other element also involved, but this is the main element. The human resource, the reliable assay, testing platform, result, the disseminations, which is interdependent among each other, with each other. And during this pandemic, the setup turnaround time for COVID lab IMR is between 24 to 48 hours, despite the fact that the numbers of samples that we receive per day is thousands. And actually we have tried our best. We have tried our best to ensure that we can achieve the target. Okay, a little bit on the timelines of the COVID lab in NIH. Actually, we started operating in IMR Jalan Pahang. We start somewhere around early January 2020. During that time, we use pan-coronavirus assay to test the samples. And later, once the scientists from China published the whole genome sequence of the virus in GSAID, or Global Science Initiative on sharing all influenza data, we take up the sequence, we refer to the sequence and design our own assay and use in our lab. And on 22nd January 2020, when Koman, which is the prominent scientist in coronavirus, has published a protocol in Euro surveillance journal, so we later adopted the protocol to be used in our lab. And during this time, we are operating at Jalan Pahang, and first week, the number of samples that we receive is only few, and later gradually increased to hundreds and later thousands per day. And later, due to a lot of limitation, because not only the limitations of the space and also the shortage of the reagents, everything, government has decided to open the lab in NIH, Setia Alam. So on 5th May 2020, we moved here in Setia Alam, and our lab capacity has been increased from around 1,000 to 1,002 at Jalan Pahang to 5,000 samples per day at Setia Alam. So that makes us as one of the biggest, highest capacity lab in Malaysia. And then to accommodate the high number of testing per day, we must have what we call that a high-end system. So to accommodate the high number of testing, our lab have been provided with a high throughput extraction system. And for the information, we only conducting real-time RT-PCR in our COVID lab. So in PCR testing, in any PCR testing, the most tedious and the most time-consuming is the extraction part, RNA extraction part. So with this high throughput system, it really helps us. And on top of that, we also have a very spacious laboratory in NIH. We have a dedicated room lab for every processing. For example, for sample processing, for muscle mix, for extraction, and also for the data entry, result registration, and so on. Another key element, the second key element is the reliable assay. Because unlike the pandemic H1N1 in 2009, where the test kit is very limited, and during this pandemic, we have seen an advance of numerous real-time PCR kit in the market. But we are very fortunate because MDA has stipulated that the only kit that can be used in the testing is the test kit which has achieved 100% both of in sensitivity and specificity, and then can be used for and must have a MDA approval letter, so that save the lab from doing a lot of verification and validation process. And another key element for us to make sure that we can perform actually is the reporting of the test. Is very important actually, even though we can produce a fast result, but it's very important for us to make sure that the result can be sent to our requester. So First, when we conduct our testing in IMR, we are using the old method. We used to convert our report to PDF and upload manually every piece by piece into email and send. And it was really stressful because we also depends on the internet line in our unit. And because of that, it takes a very long time for us to send back the result to requester. And later, our unit pengurusan specimen has come up with this great system, which we call as a SMIS or Specimen Management Information System, which expedite the result dissemination from IMR to the hospital. And it really saved us from upload the result by piece. And then somewhere in April 2020, we moved, the adopt to SIMCA system, which has connected all facilities, including private lab in Malaysia for the purpose of reporting. So despite whatever system that we use, the most challenging in reporting is we have to key in manually every single patient data, such as name, ID, sample, type, and etc. And bear in mind, we are dealing with thousands of samples per day, and really take times. So because we have to really carefully key in the data, especially the ID, so that the requester can access. The main problem occurred is the requester sometimes cannot access the data due to different in ID. But for us, we solely depend on whatever written in the form, and sometimes it's very hard to read the handwriting. So somewhere around October, we asked the PKD to key in the data by themselves, so to avoid inaccessible results. So the practice is also really help us in expedite the disseminations of the result. Okay, the last key element is a manpower. In the early outbreak, the staff involved were only from virology unit. Even though we are the biggest unit in IMR, it's around 50 of us in a unit. But later, when the outbreak getting bigger, we got help from other unit in IMR. And somewhere in October, when our sample reached up to more than 5,000, sometimes we receive about 8,000 samples per day. So we get help from others. We got help from mobilisasi staff from other states. And during that time, the outbreak is only concentrate in Kedah and Sabah. And somewhere on end of last year and early this year, during the third wave, where the outbreak was all over Malaysia, when the states taken back all their staff, so we were given the contract staff and my step staff to help us in everything. Here we have designated team for each process. We have a receiving team, we have a processing team, PCR team, data entry result teams, and also validation team to help us to deliver the testing. Okay, other than doing diagnostic, we also involved in other roles. Here, I want to highlight is the kit evaluation role. So far, we have evaluated almost 400 kits. Some of the kit is the same but different lots number and sent by different company. What I want to highlight is the evaluations of self-test kit because it really give a big impact in both health facilities and also in the public side. For health facility, I think it really helped. It expedited the tracking of positive case and also reduced the burdens of the health facility, including the lab. And for public side, it reduced stress in queuing to give a sample if you are a positive, if you are contact of a positive case and waiting for the result. So it really helped actually. So now they have an option to do testing at home with comfortable environment and very fast result. So another kit that have been evaluated is the RTK antigen which has been used in the site. So the result can known very fast and the process of contract tracing can be accelerated. So I think a big credit I should give to the kit evaluation team in virology unit, which was heading by Ms. Kavita. They have done a very good job, actually very hardworking, very hard work, including to go down to the field to ensure that enough sample for kit evaluation, especially for the self-test kit. And Other research highlight is the whole genome sequencing and vaccine development. I'm not going to elaborate details, but as a brief, viruses are constantly changing. So the SARS coronavirus 2, the changing occur over time and can lead to different characteristics as what we've seen in SARS coronavirus, and later we have this Delta variants. Because of the viral dynamic, the whole genome sequence became very crucial for us to improve understanding of the virus behavior. And another research highlight is the vaccine development. Since we know vaccines is very important in combating the virus outbreak, so it will be very useful if we can develop our own capability in producing vaccine. At least we are less depends to the supplier from outside. And okay, what is we can do for the futures? Okay, due to the impact of this pandemic, there's a lot of things that we have to revise in order for us to prepare for other outbreak in the future. What we are supposed to do, what can we improve, what we do wrong to this pandemic, and what we should have. And whatever we do, it is better if we can less dependent on others. With that, I end my presentations and thank you.
Thank you, Tengku Rogayah, for interesting topic and sharing of information about the lab work behind all this pandemic. So we really hope that in the future, Malaysia has its own vaccine and we don't have to depend on other countries. So let me introduce you to the third panelist today. We have Dr. Azah Abdul. Are you ready? So Dr. Azah is a family medicine specialist. She's working at Section 7, Shah Alam Health Clinic, which is in the district of Petaling again. Dr. Azah is also the Chief Coordinator for Selangor Family Medicine Specialist at the Low Risk Center, Maib Serdang. So her main task during this COVID-19 pandemic is to conduct clinical assignments and patient assessment at COVID-19 Assessment Center at Stadium Malawati, Shah Alam, and COVID-19 team leader at Section 7 Shah Alam Health Clinic. Dr. Azah manages patients ranging from those asymptomatics to those with various symptoms. So her topic today is keeping the asymptomatic at home, the role of COVID-19 Assessment Center. The floor is yours, Dr. Azah.
Assalamualaikum warahmatullahi wabarakatuh and very good morning. Thank you very much, Madam Moderator, and thank you for the organizer for inviting me to join this webinar. Okay, so this is a topic that I'm going to bring this morning. These are the list of contents of my presentation. Okay, let's see what the chronology of development of CAC. It followed following a directive from the DG of Health Malaysia, where the circular said all the asymptomatic and mild symptoms can be at home. So after that, we had several training sessions nationwide. And CAC is unique. We used to call it CAC, COVID Assessment Center. It's unique because the location can vary. It can be at any Ministry of Health premises, and also private premises, and it depends on the workload and the needs and the stability. So it can be at any community halls or even stadiums. So what are the functions of CAC? It has two functions. One is a physical assessment and the other is a home monitoring. So when a patient has had been diagnosed, they should come to CAC to be assessed at the initial visit. We assess the patient and we decide whether the patients are suitable or not for home monitoring, or are they required admission. Then they also come on their release day, where we evaluate them again and we cut their wristband and give them their release order. And for those who are home monitored, the home monitoring team will monitor them daily through apps. And if there are a need, they would escalate for admission and we will arrange a home pickup for the patient. CAC will also provide data to the District Health Office for further planning and management, and for certain CACs, if they have enough manpower, there are additional work that such as contact tracing and also swabs. So let's see the timeline for COVID-19 infection. Okay, on the left side is the viral load. On the right side is the antibody response, and you can see the timeline at the x-axis. So generally, patient will have mild symptoms during the course of disease until day 10. So it's under the blue line here, all right? But some patients will deteriorate after day 5, and they will progress to severe illness and even critical illness due to the exaggerated immune response. So that's why it's important for us to monitor them, although they are being home quarantined. For the clinical staging for COVID-19, this is what has been used nationwide, but for the purpose of home monitoring, we divide the category 2 to 2 sections. Mild symptoms are 2A, and also moderate symptoms are 2B. So this will determine the management of patients. For category 3, 4, and 5 will be straight away admitted to either hospital or the low-risk centers. Let's see the journey of COVID-19 positive patients. So what happened? They would be, when they are positive, the result will be entered through SIM card, and they'll be notified as positive MySejahtera, and the District Health Office will then do the primary triaging, like what the first speaker has told us, and then the patient will go to physical CAC. But during the primary triaging, if the District Health Office had found out that the patient had red flags and warning signs or not suitable for home isolation, they will arrange for admission straight away. So the asymptomatic or mild symptoms will go to physical CAC. So let's look at what happened at physical CAC. They also receive walk-in patients. The patients who are positive but has not been reached or contacted by anybody, they would walk in. And at the CAC, we will register the patient, monitor them using apps. So at in Selangor, we use Selangkah apps. Then we do some physical examination and recertify, and then we decide whether the patient has to be admitted to a hospital or low-risk center, or if they're not in the high-risk group, they'll be monitored and enrolled into the home monitoring system using the apps. We have a home monitoring team, so the patient are required to fill up their home assessment tool twice a day in the monitoring system. And everyone will be given a CAC helpline in case they have things to ask. So, so there are two, like I said just now, there are two components, physical assessment and also the home monitoring process. So if you see, to have a good home monitoring team, you have to have trained human resources using standardized questionnaires. So you have to train them. And then you have to have tools, laptops, desktop, internet connection, and also a good app. Is a bonus if patient has pulse oximeter and also other apparatus like thermometer or blood pressure set. And we must also remember what is the exit strategy for the patient in case they have imminency or in crisis. So we have to have transportation available for the patient in case we need the patient to go to the hospital or patient themselves want to go to the hospital. And of course, not to forget, we have to have hospital beds for these patients. And last, but very important, the patient themselves. We need to really counsel them that they have to do their home assessment tool. They must be warned of the warning signs and they must be truthful. So adherence is very important for home monitoring. If not, we won't be getting the data and we can't monitor the patient. So this, I'm working in CAC Malawati, that's the biggest CAC in Malaysia. We can cater for 1,400 patients per day, but at our peak time, we have we have had almost 5,000 patients per day. So what happened at the physical CAC? Patient will come walk in or appointment. They install their Salangka apps, create account, fill out personal information, and at the registration counter, we check the personal details, then we assess them. So we also have health inspectors at CAC, at our CAC, so they give out home surveillance order, and we also have, so after assessment, they either go to health inspector, or if they are deemed in emergency situation, they be admitted. So there'll be several resolution here. They be discharged to go back home with really or the given release order if they have completed isolation, and then they'll be enrolled to either home monitoring, or they'll be admitted if they have any emergency. Let's see. This is the comparison. These are the attendances for Selangor. Total attendances to CAC in purple and green in home monitoring. If you can see, this is the peak here, week 28 and 29. The home monitoring requirement is at least twice or thrice the number of the physical attendances to the CAC. It's because when we monitor them, we have to monitor them for 10 days. And sometimes there are people who monitor more than 10 days if the symptoms continue. So that's why the numbers keep accumulating. So what are the challenges that we faced? Overwhelmed primary triage. So when this happens, the district health office are not able to reach out to the positive patients on time. So that's when you see a lot of patients do not know what to do and all that. And then we have congested CAC. So they have long waiting hours, they waited outside and it took a longer time to finish assessment. We have inadequate resources in terms of human resource, transportation, and also operators. And don't forget, our home monitoring resources are also inadequate. And of course, the hospital beds. At that time, there was inadequate beds. So what are the new initiatives? Okay, one, because the DHO, District Health Office cannot cope, MOH has set up a virtual CAC. It is manned by the HQ. So they will contact now the patient, they will help. So they act as a primary triager as well. So the positive patients will be contacted by the virtual CAC. There is a new criteria for home isolation. So not all patients need to come to CAC. There's also digital home surveillance order, replacing the old paper that is issued by the health inspectors. And we have interagency collaboration with volunteers, NGOs, donation, and also private practitioners. So with this collaboration, we get more physical and also human resources. And we have, for the hospital disposition beds, we have a centralized bed management unit, and the coordinator is the regional emergency physician. And this is a new one also, community empowerment, where they self-test, they self-upload, and they self-monitor their own health, of course, with our supervision. These are the new criteria. If they are asymptomatic, they stay at home. But if they are symptomatic, or they are asymptomatic but has this criteria, more than 6 years old, obese, kidney failure, and also infant less than 1 month and pregnant, they should come to the CAC. So let's see where in the flow the changes are. Okay, self-notification, okay, self-test, self-upload, and also they receive a digital HSO. The primary triaging is now taken over by virtual CAC. And then if they're asymptomatic, they stay at home, except for the high-risk patients. And at virtual CAC, they use automation, infoblast, and all the robocall. So that will help, the automation will help the team. And at physical CAC, there's not much changes. But here we train volunteers, so the volunteers can help us doing the call at virtual and also at our home monitoring team. So that are the new initiatives. If you see, these are the numbers in blue are the total attendances to Malaysia, and the numbers in the orange line are the total attendances to CAC Selangor. I think the first speaker has mentioned Selangor contributes to about 1/3 to 50% of our total Malaysian cases. So when we did the intervention, the new initiatives, our attendances to physical CAC has reduced. So if you see CAC has moved forward, we use digitalization and automation, and also we include community empowerment in the strategy. There are, of course, pros and cons to this initiative. Okay, first, if you see, what are the pros of this patient? Outpatient management is appropriate for most patients with COVID-19. So in 80% of them, they are mild and does not warrant admission. So keeping them at home avoid congestion and unnecessary burden to the already overwhelmed healthcare system. Then using teleconsultation can prevent unnecessary in-person medical visits. It also reduces the risk of potentially exposing other people to COVID virus. In the lesser congested CAC, the doctors can focus more on the ill patients. The emergence of telehealth and digitalization and automation are great help. With massive numbers of cases, we can't do it manually. And empowerment of community is very important. They are given the responsibility to take care of themselves, their health and the family. More educational materials you can see now in the mass media. What are the disadvantages of this strategy? First, you deprive patients on physical assessment because some patients still prefer to meet their healthcare provider face-to-face. But by saying this, CAC allows walk-in. And some patients are not compliant in filling up the home assessment tool as instructed. There are a few who declared wrongly, and also I don't know whether they do it intentionally or some patients do not want to get admitted. There are also no more wristband since the emergence of digital home surveillance orders. So some patients may take advantage and go out because there's no physical wristband anymore. There is a group of patients may find it difficult to use apps like the elderly, foreigners, illiterate, and those who cannot afford even a smartphone. Do not forget the stigma of carrying COVID-19 diagnosis. This issue is often overlooked because some patients have been locked out of the house when they were diagnosed positive and they come back to us because they have nowhere to go. And of course, the upgrading of facilities and resources would incur cost, but in the long run, it would benefit everyone. So that are the disadvantages. So we'll see the strategies again. So data on primary care management of COVID-19 is still lacking. We know most patients are in category 1 and display minimal symptoms. So our strategy that we use are only available on based on the clinical experience. We're also learning as we grow and live together with the virus. So the approach actually is based also on a rapidly developing evidence-based scenario, taking into account the patient's clinical and social circumstances as well as available local resources. The approach to care is flexible. As disease evolves, treatment guidelines are also developed, adjusting to for limited resources, aim to reduce the burden on overall healthcare system. So the protocol may vary according to institution, region, and also resource availability, and it may probably change over a several-week period in response to the such number of patients. Community empowerment is the way forward. Give them the trust and accountability to take care of their own health. Knowledge on the disease should be imparted using the media platform. So so that they can also be an agent of change. The digitalization and also automation is greatly needed in managing high density population like Petaling or Selangor because it is almost impossible to do containment and contact tracing manually as we are actually in the race of virus who's faster, we or the virus. A coordinated care program that includes initial risk certification, physical assessment, dedicated CAC, and a close relationship with the local hospital or emergency department is greatly in favor for good results. Working closely with interagency and AGOs would create more physical and human resources. They can be trained and replicate our tasks. And last but most important strategy is to have a good and strong leadership that can give clear and precise instruction in a timely manner based on feedbacks from the ground and able to create a good teamwork. Okay, with that, I end my presentation. Thank you.
Thank you, Dr. Azah, for your wonderful talk this morning. Okay, just another reminder for those newcomers. So if you wish to have e-certificate, you can access it at the attendance link at the YouTube. So, and those who have questions in hand, please write in the chat box at YouTube, or you can send your question at the question submission link. Okay, now we have our last panelist today with us. So let me introduce you to the last panelist. He is Dato Indera Dr. Shaari Ngadiman. So Dato Indera is a Selangor State Health Director. He's a senior public health physician and with more than 3 decades of experience in public health program at various levels in Malaysia. He has vast experience in a wide range of public health issues, including HIV, STI, vector-borne, vaccine-preventable diseases, to name a few. He is the anchor for COVID-19 management in Selangor and also the Central Territory at one time. So he's going to share his thoughts today. His topic is management of COVID-19 patients from low-risk center to integrated hospital. MAEPS has it all. Over to you, Dato.
Bermula pada hari ini, iaitu 9 Disember, MAEPS Serdang sekali lagi diaktifkan menjadi pusat kuarantin dan rawatan COVID-19.
Dan sekarang ni kita ada pengalaman untuk menjalankan ataupun membuka semula MAEPS ni dalam tempoh 3 hari.
Thank you, Dr. Anita, for your kind introductions. And panelists, ladies and gentlemen, just now, just show to you 3 minutes video clip on how we set up MyApp's low-risk centers and treatment center in Sudan. For information that MyApp was launched somewhere in late December 2020, and 3 days later it was opened up to take a first batch of patients, and these MyApps can accommodate up to 10,000 beds. And how we run this center, we use numbers of agencies, 18 agencies and 1,800 staff, and we managed to mobilize staff from everywhere. And these MyApps have a minimum 7 halls, whereby out of that 5 halls are static and another 2 halls we developed that through the certain tent, and so far we managed to see patients more than 150,000. These are the overview of MyApps in Sudan. You can see the layout of this building, and these are the agencies involved in personalized this PKRC MyApps. Why we call it MyApps 2.0? Because earlier, somewhere in early April 2020, we opened up MyApps also to treat patients for 3 months duration, and after that numbers of cases is out, and then we closed MyApps for several months until the upsurge of cases in December, when as shown in video just now, that the government asked us to open up MyApps again for the second time. And for information that MyApps was coordinated through co-chaired by National Disaster Management Agency, or we call it NADMA, and also Secretary of State of Selangor. And I was asked to be a coordinator for this, and we have a medical director who is Dr. Shabuddin, and he's very vast experience in handling hospital also. Under that, we have a deputy director for clinicals, we have deputy directors for services, and also for management, and also for the lab facilities. How we set up this MyApps 2.0? As mentioned just now, the first hall, we have a few halls here. For example, like hall D2, where we our office here in hall D2. All agencies stationed here, and we have numbers of meeting rooms and so discussion room. And here is our heart of this MyApps 2.0. And here also another facilities is hall C, whereby earlier the hall C start work somewhere in 7th of December, where given 2-3 days to make sure that this hall C able to take first batch of patient, and the first admission was occurred in 9th of December. And later on, we improved further the hall C into 1,020 beds. We use double-decker beds, and the progress starts somewhere 23rd of December. Within a day, we managed to get numbers of patients. And another one is hall DG. DG is a ground level of block D, and here they're able to cater 800 beds, and we managed to use camp bed to assure that this facility is able to take numbers of cases. And the start work was on the 9th of December, and we managed to take a first batch of patient in this hall DG on 11th of December. Another hall is hall A. These are the biggest hall here in MyApps. Initially, it was set up for 1,400 beds, and the start work somewhere on the 10th of December, and the first batch of patient was admitted here on the 12th of December. You can see that between Hall C, Hall DG, and Hall A, within a few days time they've been set up and able to admit numbers of cases. But for the Hall A, we improved further by providing 2,960 beds. And by end of December, we have several thousand of beds available for MyAPS 2.0. Since numbers of cases increasing, the management, we have a discussion, and we managed to ask the management to set another hall, we call it Hall E. And Hall E took 10 days to be set up, and the first admission was on the Christmas Day 2020, and this hall, the Hall E, able to cater for 2,000 cases. We have 2,000 beds here. And since the number of cases was increasing, and we need another hall, we call it Hall B. And Hall B start work somewhere in 18th of December, and patients start be admitted on the 21st December 2020. In this Hall B, initially we have 868 beds, but later on we improved further on the mezzanine floor with another 352 beds, come with more than 1,000 beds available in Hall B. And here are and furthermore, with numbers of cases among the families, for example, sometimes mothers infected and their child also infected. So we have a thought that time to have, we call it family hall. And we managed to convert the Hall D1 at the Block D Level 1 to be a Malaysian hall, whereby in this facility, we're supposed to have a female side, male side, and we can also accommodate numbers of child there. Hall D1 can cater for 1,400 cases. And beside that also, since numbers of cases be admitted, when we are afraid if there is numbers of cases need further management, so we set up a district hospital in MyAPS. We call it Hall B. We converted the earlier one, as I mentioned, 1,000 plus beds into the hospital, district hospital, whereby in this particular hall we have 30 to 60 hospital beds. We have also ICU. We have also field hospital there, and beside that also we have another one, negative pressure isolation tent. Here we have 4-bedded ICU beds, and we call it Maria. Is it MyAPS acute resuscitation and isolation areas. This Maria, we managed to save lives through using this Maria area. Since numbers of cases also increasing in MyAPS, in Selangor especially, so we set up another hall, we call it Hall F. This Hall F can cater up to 636 beds. And here are the progress of how we set up MyAPS hospital. Initially on the 9th of December, we cater only category 1 and 2 for males only. But later on in early January, we include female here, category 1 and 2. And 3 days later, on 4th of January, we also start taking families, including those above 7 years old. And 8 days later, we managed to take also category 1, category 2, and category 3, all in. But later on, with the facilities improved further, we are able to take all categories started on the 2nd of February. And that particular period also, we managed to equip the hospitals with more than more than 3,000 oxygen cylinders, 1,500 oxygen concentrators, more access machine, and so on. So our aim is to assure that a patient be admitted in MyAPS being taken care properly. And our approach, as you mentioned just now, is Dr. Azah mentioning regarding case being seen in CAC, and so through Dr. Salina just now how she managed to get screening, contact tracing, whatsoever. All these cases, once they get the information and this case need to be hospitalized, we inform the Unified Command Center. And for your information, Unified Command Center is being placed in MAEPS Serdang. And there, the Unified Command Center being managed by Regional Emergency Physician. And this center will direct where the patient should be. For example, the CAC, they have cases of COVID-19, which category 1 or 2 until category 5, and where they should be admitted. It should be a day where they should be admitted in the hospital, or should be admitted in MAEPS. For information, earlier that we have Hospital Sungai Buloh in Selangor is a fully COVID hospital. Veterans, we increase further to a few more hospitals to be COVID hospital, i.e. Hospital Ampang, Hospital Selayang, and Hospital Serdang. There are 4 hospitals in Selangor being converted into fully COVID hospital. And Hospital Shah Alam will be non-COVID hospital, and the other hospital in Selangor is hybrid hospital. Whereby in Kuala Lumpur, HKL and also Cheras will be a hybrid hospital. These are numbers of facility that we send cases through Unified Command Center. And then the Unified Command Center will, after they divide the cases, then they will, we have our officers where the MAEPS or in hospital we take care necessarily. And in MAEPS we able to see cases 24 hours. Any cases being sent to the MAEPS, we are working for 24/7. In MAEPS, we have a different approach. For the category 1 and category 2, we have health centers in each hall. Each hall, we place in numbers of medical officers, nurses, and paramedics, and also the physician in charge is the family physician, will be the person in charge for the health centers in each hall. And these health centers operated daily from 10 a.m. until 1 p.m. For the other category, 3, 4, and 5, they will be managed at Hall B and at the Maria, as I mentioned just now, is MAEPS acute resuscitation and isolation area, also for 24/7. And in Maria and Hall B, be managed by physician and also emergency physician. Another one is, as I mentioned just now, Central Bed Management Unit. So the aim here is to make sure that admission and discharge be managed properly. We have also take care of our daily statistic, diet. We have also placed for patient requests and any complaints from the patient, any family requests or sending materials for the patient, and also liaison for our internal or external requests. For the pediatrics and family medicine issues, the case with the management will be run by family physician, and through our family physician in Selangor, we take the rotation every week. So the family physician in Selangor take their turns weekly, and they did rounds, daily rounds, and they only manage pediatric cases above 3 years old, and also any pregnancy above 20 weeks. And for your information that here in MAEPS, we have numbers of physician, emergency physician, obstetrician, pediatrician, and FMS here. And in MAEPS also, we've been supported by at least 650 nurses. We have 800 medical assistants. We have roughly around 250 medical officers. And in MAEPS also, what we have also medical transport unit, whereby we have numbers of ambulance, we have numbers of bus, we have also numbers of bus ambulance for patient transfer and also for inter-house transfer, especially for X-rays. To assure that patient being taken care properly, there are also pathological services, radiological services, and other things that in MAF, and we have also mental health and psychological support service being given to patient and also staff. Up to last week, we managed 151,545 cases, whereby 58,000 was among foreigners and the rest are Malaysian. And most of the patients, 66% are male. And for your information, for MAF Sabdang, we are not only taking care of patients in Selangor and Kuala Lumpur, we did also receive patients from Negeri Sembilan, neighboring state, Negeri Sembilan, Melaka, Perak, Pahang, Johor, and also Terengganu. How we manage this MAF 2.0? We managed to succeed till now because number one, being supported by political will of our leaders. Our leaders want to make sure that patients being taken care properly, and through setups of MAFs, and we use that MAFs to convert MAFs from agricultural exhibition center to the hospitals. Number two is we managed to get through because we have a workable policy. As mentioned by Dr. Azah just now, the policies set up from central level until the state level and also at the district level, we use that kind of policy to assure that this center be managed properly. And the reason why we try to do that, because we try to save life. The number three, why we managed to succeed, because participation from all parties, especially any agencies related to care and also to assure that services are being given properly. And number four, we strive to persevere to do services to our people. Besides, as I mentioned just now, we have also a few facilities for the patient inside the hall. We have also mini playground for the children being admitted. We have also a gymnasium for these people, the COVID cases in their each hall. We have also prayer area for them. We have lounge, and we have also digital community center whereby any patients who want to use that for communication and even to look their emails or whatsoever, we can use the digital communication center that provided in each hall. As I mentioned just now, we have also converted buses into bus ambulance, and to assure that oxygen-based supply in MAF uninterrupted, we already set up a mini oxygen filling plant there in MAF itself. To assure that our staff are also healthy, not burn up, and also assure that patients will take care properly, we set up a mental health psychosocial support and being managed by our doctors and also counselors. There's numbers of counselors being placed here to provide mental health psychosocial support. Definitely, once we put patient there, we have certain clinical waste. We do manage clinical waste properly through our system, and till now we have more than 230,000 kilos of clinical waste, and including 174 kilos of linen and laundries. See numbers of all those being used, and how we try to assure that the facility is able to cater and taking care of all those needed in this area. We try to make sure that safe clinical services and safe waste management. Besides that, also in MAF, all patients' reports being converted into digital system. We call it PKRC bersepadu MAF, digital system, CPRC hospital system. All patient data being kept in CPRC hospital system. Definitely, once you run this center definitely we have certain challenges, and how we try to solve this problem. And definitely, the most important thing is we should discuss it through our meetings, discuss with our agencies and so on. And certain issues regarding clinical issues also been taken care properly by our physician there. And since at the beginning we had only limited numbers of cases, until certain time up to 8,000 cases be admitted, definitely we need to upgrade the online system there in MyApps. For your information, MyApps are fully, they have 5G Wi-Fi there, but although it's a 5G Wi-Fi, sometimes if not all patients are using that line, definitely there is some hiccup there. But we try to make sure that the system will functioning properly. To assure that the services be given at the most level, so what we did, we mobilized numbers of staff. The staff mobilization not only from Selangor and Kuala Lumpur itself, but also throughout Malaysia, including Sabah and Sarawak to MyApps. And any urgent matter we need to discuss, we discuss it there, we solve it there in MyApps itself. This is how we try to assure that MyApps will provide care for the patient, and we try to serve MyApps as the example of how Malaysian taking care of COVID-19 in our own way. Thank you.
Very much, Dato Indra, Dr. Shaari, Ngadiman. So I think all of four panelists have already shared their thoughts about COVID-19 pandemic, managing a different level of intervention. So we will open this panel discussion, and we already have received tremendous questions from audience to our panelists. But of course, I would give way to most common questions that are asking about one issues about COVID-19, which is BID. So I'm very sure that all our panelists today are well prepared to respond to BID. So the questions, would like to forward this to Dr. Azah Abdul Samad. Okay. So there has been an allegation that BID were related to home monitoring because there's no professional monitoring of health. Okay, what is your view about this? That is first, right? What is your view about whether the allegation has basis or not? So the second question is about estimated 25% patient actually filled up the report and report to the virtual monitoring. How best can we do, or what strategy do you have in mind to improve on self-reporting? Because this is related to your suggestion that this virtual health monitoring would be very useful if patient or everybody is truthful in reporting. So what is your response, Dr. Azah?
Thank you, Dr. Anita. Well, so there are several questions there. So probably I would take the first one, that BID are related to strategies home monitoring. Well, there has analysis of the BID has been done, but there are not all cases have been discussed. About 60 cases have been discussed. Well, there are challenges to home monitoring, but there are several levels. You can see, because it's related to virtual CAC, which is meant by the HQ, the PKDs, the CAC, the hospitals, and also back to the patient. So probably at the virtual CAC level, if they have enough resources, and even at the PKD level, enough resources, and there's automation. Like if they have a good system where if patients do not report, it will pop up. So that'll be a reminder for the patients. That'll be very good. And that is at the virtual CAC and PKD level. But at the CAC level, there are cases that probably missed. It's not diagnosed appropriately maybe, but we have family physicians there. If the patient, the doctors are not sure, they have to consult us for any change in category and any plan for admission. And also at the level of the patient itself, they have to know that enough counseling should be done, be given to them, that their response is very important to make sure the home monitoring is runs smoothly. And maybe this is just maybe, if you can, it's not a punishment, but if they don't enter their home assessment, maybe you don't give them the release order, maybe, because they need that release order to go back to work, to go back and to go to the malls and everything. But we have to make sure they put in their home assessment, then only we give them this. Or that's those I can think of. About the monitoring, all virtual CAC and even CAC, and also the CACs that are run by volunteers, we have specialists there. We have non-medical volunteers, we have non-medical people, and also we have medical people. So there's no issue of no supervision by the specialists or the professionals.
Thank you, Dr. Azah. Thank you, Dr. Azah. Yeah, well, I think there was just an allegation, so there is no right and wrong answer for that. But again, on the same page, I would like also to pose a question to Dato Indera. It was so amazing, like how PKRC and integrated hospital was put into function just a few days with full capacities to cater for the rising number of cases. But lately, many had died before they even reached PKRC or hospital. Dato Indera, do you have any logic explanation for this?
Thank you, Dr. Anita. It's really a difficult question for me. But I try to figure out why that thing happened. Number one is recently there is a change in the policy regarding testing of the cases, whereby anybody asymptomatic, there's no symptom, no need to test. My worry is, for example, if the particular person close contact with someone and then test was not done, and if you can recall back what the slide shown by Dr. Azah just now, when it happens for patient to develop symptom, my worry is suddenly patient develop symptom and within a few hours they have a severe illness and not enough time for them to bring patient to CAC or to the hospital. That is one instances. Number two is regarding, for example, virtual CAC. Dr. Azah mentioned just now, we have pro and cons on virtual CAC, and if patient don't understand fully how to report or whatsoever, my great worry also, if they didn't use, for example, pulse oximeter properly or didn't report it properly on time whatsoever, and they miss that kind of the missed opportunity, the certain golden hours for them. If they miss that period and turn to be in a severe condition, then unfortunately unable for them to bring the patient faster to the hospital or also to CAC or to MAS. There's two conditions. The third condition is patient not aware that they are having COVID-19. Suddenly, every day I'm like this, and suddenly they feel dyspneic. Middle of the night, they feel dyspneic, and suddenly cry for help. And that time, for example, during the COVID-19, the 999 also quite busy and whatsoever. My problem is, if there is they miss the communication between patient and also facilities. These are the third factors maybe that why BID is occurring. That's why I urge that anybody with close contact of COVID-19, please test yourself and please make assessment. Assessment is much needed. Either you do assessment at the CAC or try to answer all the questions under virtual CAC. That one is very important for us to assure that you still keep healthy. And the most important also for all of us, besides vaccination, please adhere to masking. It's more important in currently. Okay, thank you, Dr. Anita.
Thank you, Dr. Indra. I think based on Dr. Azah and your response, Dr. Indra, it boils down to the attitude of people. The other thing is that we can have an apps, superb apps, to track health and things like that. But if the users are not in favor of using that apps or not truthful, like what Dr. Azah just said just now, it won't work that way. Now, on the same page about CAC, there's been a question about CAC directed to Dr. Salina. Now, that's a comment from Johor. So we have started virtual CAC in Johor too, right? Yet somehow the uptake by the public remains around just 40%. So in a way, they are saying that 60% of people rather go for physical CAC, not virtual CAC. Why? Probably, I guess people don't like to speak or just to talk to a machine or handphone. Well, despite the use of all channels of promotion, public uptake of this system still low, right? Whereby they prefer to prevent themselves with family. They come, the whole family come to CAC, physical. So this is itself lends to indirect increase of cases within the community. It would be good if you could share, if you have any strategies in mind, how to improve the uptake of virtual CAC among general public. Maybe it is not only directed to Dr. Salina, so probably this is a discussion, probably in between Dr. Azah or Dato Indra also can chip in.
Right. Thank you for the questions, Dr. Anita. We are facing the same issue where maybe public are either not ready to change, inexperienced, having unstable internet bandwidth, or having issue with the data protection. And we can't enforce them as digital methods for tracking infectious disease in Malaysia are still not being explained in depth in our Malaysia CDC Act. But having said that, this is one of the initiatives that we are using. Apart of that, we have many other strategies to reduce the number of cases not being traced or to reduce the number of cases not being showed up and being assessed for their COVID disease. What we did in Petaling district, we are trying our best to mobilize our human resources, especially to the essential teams such as surveillance, case investigation, contact tracing, and even COVID assessment center. We shared a database to be used with all the team members so that this reduce the duplication time and time spent for data collection. As I explained earlier, we also developed a self-reporting system as explained, as discussed, and the InfoBlast system. What we normally do, if cases or contacts are not responded to the InfoBlast or they do not self-report, we will contact them manually. It's better for them to go to physical CAC rather than being brought in that. So in conclusion to that questions, I think what importance is community empowerment, leadership, and collaboration with all the participants, affected agencies actually, must be warranted to reduce to increase somehow the number of patients coming to be assessed for their COVID disease. Thank you.
Thank you, Dr. Salina. That's a question I would like to direct to Tengku Rogayah. If you are asked to increase testing capacity in the country, if you can see that now Selangor, the new cases is already in the decline pattern, and so do mortality and BID. But in other states, you see that it is increasing. All right. Now, in view of possibility of increasing number of testing in this country, what further innovations would be needed? Over to you.
Okay, thank you, Doctor. Actually, in order for us to make sure that we still can successfully deliver the missions where to submit the result within 24 to 48 hours during our turnaround time. So that's we have to venture in the innovations of cut short of the PCR testing. One of the factors is to cut short. Nowadays, there's a lot of testing, the PCR test where they decrease the number, the process of extraction, and some they process PCR without the extraction. So maybe we can do that. Actually, we can adopt the protocol. And another issue that we have to cater is the how fast we can cut short data entry in the SIM card system. I think that's it.
Okay, thank you, Dr. Azah. Next questions, I would like to revert to Dato, Dr. Indera, Dr. Shaari bin Ngadiman. All right, so that's issues or questions about MAEPS. Yeah, Dato, to run these extra beds in MAEPS utilizing existing resources, despite mobilizing from other states, do you see any effect on performance of other essential health services like, for example, MCH, non-CD within the state, which will impact on health status in the state for long term?
Thank you, Dr. Indera. Thank you for that question. And definitely there will be some effect on those you just mentioned just now. But for the time being, we didn't measure that, but we assume that there will be an impact. And to assure that the services still running, what we did, we allow 25% of our daily cases being seen in our facility, especially in health centers. We improve other facility, for example, like drive-through. We lengthen the duration of prescribing from 1 month to 3 months or 6 months if needed. And sometimes we allow also for the patient to communicate with their doctors if they have the facility. Like the virtual CAC, what we did, we communicate with patient through our facilities and also patient to assure that non-CD is being managed properly. For the MCH also, we didn't disturb the facility, but we reduced to 50%. For others, non-CD, we reduced to 25%. This is how we approach in our health facility. And why we reduce that? Because we try to use staff to be mobilized in the CAC and also PKRC, and also doing for contact tracing. Okay, thank you.
Thank you, Dato. This is the next question is for Dr. Azah. Dr. Azah, we were talking about backlog of cases just now in your presentation. Now, there's a question seeking your opinion, so that this is coming from other states. They are facing with increasing number of cases, so they have seen that how at one time Selangor was had faced issues on transportation. So people have been waiting at home, for the ambulance or transport to arrive to bring them to either to hospitals or MAEP. So at the end of the day, they waited. They have to call for a private ambulance like that, and the cost, escalating, things like that. So, but in other states, they are now seeing what is happening in Selangor before, so they would like your views or your suggestions, strategy. How can they tackle or be prepared with transportation issues should their cases increase like Selangor?
Okay, thank you. Yes, ambulance transportation has been a problem at our peak. But what I can say here, because some patients have emergency conditions, some are not, but require admission, which sometimes we see them and we say, okay, wait for the beds. So what we can do is, what we have done actually, we roped in our and other agencies like our local authorities. We have 4. So we rope in, we say we want to use their transport, their vans, and of course the state government, and we can also go to our YBs. So they will provide us with transportation vehicles, the MPVs. So these vehicles can be used for the non-emergency. So in that, if we use that for the non-emergency, so our ambulances or any St. John's and everything can be used for the emergency cases. So we strategize, we prioritize who uses the ambulance and who can use the the ordinary vehicles, right?
Thank you, Dr. Azah. If we can mobilize whatever resources that could provide the services of transportation, I think other states should be prepared.
Dr. Anita, maybe I can chip in on that.
Yeah.
Yes, recently also we improve hospital ambulance services by outsourcing the ambulance service. We ask the private sector to chip in and paid by the government on that matter. And at the same time also we enhance the calling system to assure the patient being reached. This is the 2 approach that we're using there. And the third one is we also improve further by having extra vehicle donated by one of the agency, 30 of them for the Klang Valley to transport patient. And number 4, we convert 5 buses to be as a bus ambulance. Through that approach, we hope that I think number of cases been managed to be seen timely. Thank you.
Yeah, thank you, Dato, for your input. Certainly, there must be a central monitoring, that manage this whole transport, whether it is coming from private or whether it is coming from within state of health department, or whether it's coming from other government agencies. So who actually at Selangor manage the mobilization of this transport, or giving call number and monitor who's to be fetched first?
So we are using the central calling system, and the base management unit they will respond for that. And whatever call we are going through the regional unit and through the base management unit. Yeah.
Okay, thank you. Dr. Salina, that's a question for you. What is the difference because you mentioned about the before and the after the innovations in doing things, especially the contact tracing, monitoring, so what is the difference in the outcome, right, of case investigation and contact tracing after the implementation of those innovations? Do you feel or do you see improvement, or do you feel that something better should have been done?
Thank you for the questions. Yes, in my presentation, our data only showed about 40% of cases, as well as contact responded to self-reporting data through the system. So this 40% actually reduces our burden for the case investigators and contact tracing investigator team in terms of data collection, and the time spent reduced to half for those cases and contact needed verification of the data. But and otherwise, if the data are complete, we will not call the case or the contact. All right, and this will increase our tracking for cases and contact coverage. And if you see, if you remember earlier, the reduction of a number of patient or contacts not traced is reduced tremendously, even with a huge number of cases and contact need to be investigation. And I think on top of that, the number of team members that we put in each unit are also increased to cater the number of cases that we have to investigate. But I think, as I mentioned earlier in my questions, in my answer previously, our public are not well versed with the system yet. They are still have some doubts of the system. So we still need to call them. Yes, we still need to call them. But if they already key in the data and it's complete, we don't have to call them anymore. So the coverage for tracking will be increased.
Thank you, Dr. Salina. There is another question for Dato Indra. So it's quite lengthy. So let me read to you. I have had access to the strategies advocated by the Greater Klang Valley Task Force. Okay. Honestly speaking, most of the strategies are actually in line with WHO advocated strategies as well. As I'm sure JKN strategy, as Dato Indra is known as a widely experienced public health specialist and subspecialist, the greatest problem faced is still, of course, implementing the strategies in limited resources. The question for you, Dato, what was the one factor that allowed successful implementation of these strategies within the limitations of resource and poor public cooperation?
Thank you, Dr. Anita. This top order question. Actually, if you believe in yourself, this is the answer. You must believe in yourself to assure that whatever you think, whether it can be done or can be done, you must believe in yourself. You say yes, please do it. Just do it. Actually, how we manage to run the program in Selangor, I know that 30% of cases in Malaysia happen in Selangor, and we have the biggest COVID assessment center in Malaysia. We have the biggest low risk center also in Malaysia, in Selangor. And the success story is we evaluate while we are doing. Don't forget, most of people, what they did, they just implement, wait for certain time, then they evaluate. No, I don't believe on that. We must evaluate while doing. How I evaluate that? Every day we have meetings, usually around 1 hour, from 8 until 9. All the deputies, all the important people must attend and brief. What are the things that we implemented? How is it doing? Please give feedback. This is the thing that our secret. We share all those within our system and inform. And later on, if we don't believe on this, for example, as Mr. A give this kind of information, and through the meeting, we thought that one maybe and maybe not. Okay, go to the site, look into whether they implement it or not. If they didn't implement it as you wish, please change it. That's why I said you must evaluate while doing. Same also in the PKR-SEAMEO also, we have quite numbers of meeting. That meeting is evaluating meeting and decision meeting. And after we make decision, they implement. And 2 or 3 days later, we evaluate whether it's okay or not okay. This is the secret of our ways of doing in Selangor. Thank you.
Okay, Dato, thank you very much. On the same notes, you can see that Selangor is lucky that being the most urbanized state in Malaysia, you have the biggest exhibition center that you can set up a low-risk center there. You have most hospitals well fully equipped for COVID-19 that you can convert that into a COVID-19 hospitals. Well, this is a question from other states who does not have the luxury of having big premise or non-health premise that they could convert into a low-risk center. So in those states, Dato, what would be your advice if they want to set up a PKRC or low-risk center without having, big premise like that? What would be your advice to those states, if they wish to open up a low-risk center?
Yeah, thank you for that question also. So yeah, Selangor is one of the developed states in Malaysia, and we have numbers of referral hospital at the tertiary hospital for Malaysia. Sungai Buloh Hospital, Selayang Hospital, Ampang Hospital, Serdang Hospital, other referral centers for Malaysia. And definitely we are very fortunate to have numbers of big buildings and MIFs in Selangor. And for those states who don't have that kind, you still have the facilities. For example, a school, we can convert school for example, like during now with the school, all schools are being closed. We can convert school into MIFs like facilities, and especially if there is also a boarding school whereby beds already available, change that. There are numbers of boarding school throughout this country. You can change that boarding school into MIFs like. And I did before, for example, like training center belong to our ministry in Sungai Buloh. We convert the training centers into MIFs labs. For example, during that period, MIFs are really full. We changed that training center into 4,800 bedded facility for patients. That's why, if you wish, you can do it. Just change whatever you think that is appropriate for the patient. Thank you.
Thank you very much. So this question is directed to Tengku Rogayah. Okay. Now, Tengku, recently our Minister KJ announced that Malaysia will enter endemic phase by end of October. How will this affect the lab function?
Okay. Okay, the transitions to endemic phase is very depending on the condition that enough people will gain immune protection from vaccinations or from natural infections, and there will be less transmissions of the virus and much less related hospitalizations and death due to COVID. So, but let not forget that during this endemic, the virus is still there, the virus is still circulating. So from my point of view, the testing is still important, but the number of testing will be gradually reduced from time to time. And for the lab direction, actually during the endemic, frankly speaking, we are still waiting for the national policy on the testing. Thank you.
Thank you, Tengku Rogayah. So the next, you're talking about, Dato, just now you were talking about converting schools into low-risk center. Now that's a question. I want to bring all of you away a little bit from the health system and managing COVID-19. There's a question about worry of parents about opening up university campuses, right? Schools, right? So what is your recommendation or your suggestion only for those day scholars? It's not residential students, the day scholars and the staff, you know, who commute every day to and out campus or schools. What would be your recommendation for these people? In addition to health declaration, right? Should we do antigen tests weekly or monthly before they enter the campus? Like in other countries, they are doing it, you know, like for example, twice weekly or even weekly. So anyone, the panelists can give your suggestion about this.
Actually, it's a no size fits all. So they must have a multi-pronged strategy, and we must be sure that testing is not only the ways of dealing with COVID-19. What the thing workable now? Number one workable is vaccination. Definitely. No denying about that. So please make sure that vaccination being given. Number two, what is a workable thing now? Wearing mask. Please wear that. Number three, what is workable now? Social distancing. Do that. And to assure that these three happen together simultaneously. It's not by having as before. For example, those in one class, 50 students. We cannot do that the same thing. We cannot expand the class. But how to make sure that three things happen together? Vaccination is definitely okay. Masking definitely okay. Social distancing, definitely. Physical distancing, definitely. We have to reduce numbers of students. Am I right? So, and how by reducing number of students? Okay. What happened to the students who have not turned up to the school? We can have number one, either still continue the PDPR again, or simultaneously half of these students attend physically, another half PDPR, same class. Next week, your turn will be next week, and then another. So you have to do that way. So three workable approach must be done simultaneously. What else? Physically, you must make sure that you are healthy. How to make sure you are healthy? Huh? So you use a checklist as Dr. Azah has. I don't have this fever, I don't have this, I don't have this, I don't have that. If you have a contact with these people, what next to do? As in the virtual CSC, do that. So whatever it means that whatever we are doing now must be implemented as a daily business, daily life. This is my 2 cents, doctor.
Thank you, Dr. Indra. You know that previously Selangor was the state with highest hit number of cases of COVID-19, including mortality and also BID at one time. Now you can see the statistic nowadays that Selangor has tremendously reduced the number of new cases as well as mortality BID. Now, apart from vaccine coverage, Dato, because you know that even though one is vaccinated, they can still get infected, they can still transmit. Now, apart from vaccine, good vaccine coverage or highest vaccine coverage in Selangor, what important factor that actually or you have a secret ingredient other than that 4 Ps that you mentioned just now in your slides? Is there any secret recipe that you can share with other states, how you actually bring down, how that number of cases actually reduced in Selangor?
Thank you, Dr. Anita. Also, it's a difficult question for me. I didn't keep the secrets. So, because by having the secrets, it's no point. The moment you die, nobody knows the secret. It's not good for the people.
Secret recipe is good because you have you have the cakes, everything, a secret recipe. So you need some secrets anyway.
So for in Selangor, we still continue the same testing strategy. Yeah? You must understand that 80% of tests in Selangor being carried out in private facilities. Anybody wants to go for testing, go for it. I'm much happy now because the positivity rate in Selangor, it was almost 25% before, now less than 10%. We still continue the testing strategy. If we didn't continue the testing strategy, my great worry is those people symptomatic will transmit the cases to the others. Silent transmission. My great worry is that this silent transmission happen if the most vulnerable people, the numbers of deaths will occur. That's why I said in during COVID-19, must make sure that your testing strategy is correct. Anybody need test, please do so, because they must make sure they are healthy still. And number two is provide right information for the people. And number three, communicate with all those needed, whether in the State Department or in the state government or the other agency. Please do provide right information.
Having said that, Dato, let me reiterate what you just said just now. In Selangor, you are actually testing all possible cases, not limiting to only symptomatic cases?
At the government facility, we do. But since numbers of cases, 80% of our people being tested at the private side, and only 20% in the government side. In the government side, if we see that the patient is close contact, they come with close contact with, we did test still, because part of the WHO strategy to must make sure that the positivity rate below 5%. If you tested all those only symptomatic, you can get that percent. Your positivity rate is sky high. That's why the close contact, because you must understand that we have numbers of people who are who are being vaccinated also can get infection. So by having a vaccination, you only reduce two. Number one, severity of illness, and number two, you are reducing death or reducing hospitalization. This is a function of the vaccine. We didn't cut the transmission. But for those who close contact with the positive case, they need also to do the test, because and my great worry is if these people didn't do the test and they are not being put in quarantine, they will go anywhere, as Dr. Azah mentioned just now. Pro and cons on the virtual CSE. They can go anywhere they like because they don't, nobody monitor them unless they want to use the Masajatra in the facility shows you are close contact. Or otherwise, you just go blindly. So that testing is much needed to assure that we're able to reduce the transmission.
Thank you, Dato. I think again, I think Selangor is just lucky because you have a lot of private hospital and centers where people can just walk in and get their blood tested for COVID-19, regardless of whether they are symptomatic or not, or whether they are contacts or not. Anybody can just go in. I think this is a way. The difference between Selangor, I guess, with other states, where in some states people are focusing more on the symptomatic cases only. Thank you, Dato, for that response. Now, there's a question again about the spread of COVID-19 among healthcare workers. For the question is that we cannot deny that COVID-19 do affect healthcare workers. All right, and it's pretty alarming. So what can we do to prevent this, and how do we overcome this? Probably Dr. Azah, you know, because you are very close to the healthcare workers, you see them daily, So yes, increased number. How what do you think? What you have in your plan to prevent this from happening in the future?
Okay, for the healthcare workers, they can be infected actually by two ways. One is probably in the community through their families, and second is of course at the workplace. At the workplace, if we implement wearing the PPEs, adjusting to the following, adhering to the SOPs, would probably be protected. The risk is very much less. But it's when they are outside of the facility, then you can't control them. So, but what we do is, if we know they have symptoms and because they are healthcare workers, they have symptoms, they are in close contact, so we'll probably test them and not let them come to work, to let them spread. Because we are healthcare workers, we can, if we don't want them to spread to other healthcare workers or even to the patients. So it's basically back to them also to adhere to SOP outside the healthcare premise.
Thank you, Azah. Dato, just now you were talking about schools, student going back to school. Now again, talking about children. You know that there are many instances that both parents are infected, so leaving behind parents, children's unattended. So maybe you can share, how Selangor tackle these issues. Is there any specific strategy to take care or to how to say protect or to give their life back, especially those kids or children's home parents both are infected, admitted, or even died of COVID? This is a bit outside the healthcare system.
Oh, thank you, Dr. Anita. Still related to health, what we did in hospitals and also in MAEPs, for those children infected, number one, children infected and mothers or parents negative, discordant, so discordant cases. For this case, we assess the children and also inform the mothers. Either children need to be admitted, and when we counsel the mothers to take care of the children, and we ask the mothers to put in a consent that she will take care her children, and where we place these cases, we place these cases in MAEPs. And we have a special area whereby we put a discordant patient there, and they follow through and we examine both. And we also did a test before and after being discharged to the parents who take care of their children. That one is for the discordant children positive. For the mothers positive, and they have the children, number one, our approach, we inform the parent, please, if is there anybody else to take care of the children? And their relative, they inform their relative and the relative to take care of the children. But we also ask them, please do test before and after the release. Among those relative are discordant cases. This is the approach being done in Selangor to assure that we take care of the children, at the same time assure we try to prevent the transmission. At the same time also, we ask them to adhere to the special protocol, masking and also gowning, whatsoever, to prevent the transmission. Okay, thank you. And okay.
Thank you.
Yeah.
Okay.
Yeah.
Thank you very much, panelists. I think we have already reached the end of the sessions today. 2 hours is rather too short because there's still a lot of questions need to be addressed. However, those questions will be addressed by speakers or panelists through email. So I would like to wrap up this whole webinar today. So we have learned a great deal of information about digital technology, how it is being forced or to replace, or I would rather say enhance the traditional, the manual modes of contact tracing and patient monitoring. So tracing the threats, testing, quarantine, isolation are key to public health measures if we want to combat COVID-19. There is no two ways about it. However, it must be done in a different way now. So we also have learned how Selangor, with limited manpower and resources at the beginning of the pandemic, were able to identify, quickly convert non-health premises, which is MAEPs, into an integrated COVID-19 quarantine in just few days. There are more, of course, to learn about COVID-19, and I hope there will be a sequelae of this kind of webinar in the future. And finally, on behalf of the organizer, I would like to thank all panelists and audiences for your valuable time, especially on Monday, till we meet again in another platform. But before that, there's an announcement to make. Don't forget to join our next webinar. Our next webinar title will be Prioritizing Environmental Health for Healthier Communities in Global Recovery, which is that will be on the 24th of September 2021. And lastly, stay safe, be positive, but stay negative. Thank you very much.